coming to pathomechanism, so both the conditions, chronic kidney disease as well as heart failure, can exacerbate the conditions of each other. How a heart failure can worsen CKD and how a chronic kidney disease or even AKI can increase the heart failure instances is beautifully depicted in this cartoon. So by virtue of atherosclerosis, increased risk of diabetes, arterial hypertension, wasting in cachexia can lead to increased progression of chronic kidney disease. And on the other hand, increased incidence of anemia, low hemoglobin, low iron, low erythropoietin, hyperphosphatemia, increased PTH, increased FGF23 can all lead to increased cardiac hypertrophy, increased fibrosis that lead to failure. So there is a complex interaction between the mechanism of heart and kidney that led to this cardiorenal syndrome. Now, when we look at the therapeutic strategies in heart failure, we all know the 5 pillars of therapeutic strategies in heart failure. The most commonly used these 5 pillars include the SGLT2 inhibitors, ACE inhibitors or ARBs, mineralocorticoid receptor antagonist, ARNI, and beta blocker. So this graph shows, this cartoon shows the relative how they act on the heart and kidney. So SGLT2 inhibitor, we all know it's a very good drug. Recently discovered, almost 7-8 years has been passed. And how they do, basically they decrease the proximal tubular hyperreabsorption of glucose and sodium. And by that, they vasodilate, they vasoconstrict your afferent arteriole. And initially they decrease the GFR, but later we can flatten the curve of CKD slope. Similarly, we have ACE inhibitors, and we all know it acts on the efferent arteriole by vasoconstriction. They prevent the vasoconstriction of efferent arteriole and lead to systemic and glomerular hypertension. We have mineralocorticoid receptor antagonists. They inhibit aldosterone-mediated effects like mesangial cell proliferation, podocyte injury, sclerotic changes, and arteriolar hyalinosis and aldosterone escape. Beta blocker. They basically inhibit the alpha and alpha adrenergic mediated afferent arterial vasoconstriction. They act on beta adrenergic mediated renin release also. And we have ARNI. So today the talk of the molecule is ARNI, which the ARNI is basically a composition of 2 things. One is aldosterone receptor blocker, that is valsartan, and another is neprilysin inhibitor, that is sacubitril. So it's a combination of sacubitril and valsartan, and it inhibits the degradation of nitrotropes that through cGMP generation mediates decreased sympathetic nervous stimulation, decreased afferent arterial vasodilatation, leading to increased GFR, decreases plasma volume, and decreases potassium relaxing contractile mesangial cells. So these are the 5 pillars of therapeutic strategies in heart failure, which come handy to our patients. Now, where can we use these molecules if patient has chronic kidney disease? So if GFR is more than 60, we can use any number of molecules at any place depending upon the patient's conditions. And many times we use almost 4 or almost all 5 drugs simultaneously. But once GFR is below a certain level, we have some restrictions. We cannot use 1 or 2 or 3 molecules. So here is a comparison of various therapeutic strategies like RAS blockade, beta blockers, mineralocorticoid receptor antagonists, ARNI and SGLT2 inhibitors. Apart from that, we have other molecules like ibabradine and other molecules also to use in heart failure patients. So if GFR is more than 60, nothing to worry about. Even 30 to 60, we can use all the molecules. But once your GFR goes below 30, especially for ACE inhibitors, ARNI and MRAs, we have some restrictions. We need to monitor your serum potassium. We need to monitor eGFR, and also how can we modify the doses, and when should we stop which drug I would let you know in my next few slides.